When we think about how doctors handle pain, something everyone experiences but feels so different for each person,
Hmm.
you might assume it's pretty simple. A pill for this, maybe something stronger for that.
Right.
But the material we've been looking at, it paints a much more detailed picture, really structured.
It really does.
So today we're doing a deep dive into something called the analgesic ladder. It's this fascinating framework, surprisingly specific actually, that guides how pain treatment progresses. We're pulling from some key bits of an important text on this.
Yeah, and our mission really is to walk you through this ladder step by step. We want to show how different levels of pain, they trigger different strategies,
Okay.
and why having this kind of structured approach is just so vital for, getting pain relief right. It's definitely not just about which drug to pick. It's about the whole progression. Thoughtful.
Okay, let's get into it then. Let's start at the bottom. Step one, this is for mild pain.
Yeah.
We're talking, say, a 1 to 3 on that 10-point pain scale. Pretty low-level stuff, maybe a slight ache, a minor headache. What kinds of simple, everyday medications usually come to mind first for that?
Well, for that first step, the standard recommendations are usually non-opioid analgesics. So think NSAIDs, nonsteroidal anti-inflammatory drugs, or aspirin, acetaminophen, stuff like that.
Right, the common ones.
Exactly. But here's where it starts getting interesting. Even at this mild stage, the source mentions potentially considering a slow titration.
Meaning gradually adjusting the dose?
Precisely. Gradually adjusting the dose of short-acting opioids. And this could be just as needed, or even on a schedule.
Even for mild pain, that's surprising.
It is, isn't it? It shows this proactive approach. It's not about waiting for the pain to get bad. It's about controlling it early,
Yeah.
carefully, to stop it from escalating. Kind of flips the script on toughing it out.
That really does change the perspective on step one. Okay, so
Mm.
being proactive right from the start, what happens if the pain gets worse, though? Moves up a level.
Yeah, so step two.
Let's talk about persistent or moderate pain, maybe a 4 to 7 on the scale. So, more significant, definitely noticeable, but not totally overwhelming yet. What's the main change in strategy here?
Okay, so for moderate pain, the key change is adding a weak opioid. You keep the non-opioid that was started in step one.
Ah, so you add to it.
Exactly. You add something like, say, codeine or hydrocodone. And often you'll find these actually available in combination with those non-opioids like acetaminophen.
Right, those combo pills.
Yeah. And again, that idea of slow titration of a short-acting opioid, maybe every 3 to 4 hours as needed, that's still on the table.
Okay.
But here's a really crucial point for moving up again, the trigger. If someone consistently needs 4 or more doses of that short-acting opioid per day,
4 or more, that's specific.
very specific, that's the signal to think about adding or maybe increasing the dose of a long-acting opioid. And that decision is based on the total amount of short-acting opioid they've been needing daily.
So it's quite data-driven. You're tracking the usage to guide the next step.
Absolutely. It's methodical.
All right, that clarity makes sense. Now, let's climb higher, to the top rung, essentially. Step 3, persistent or severe pain. We're talking an 8 or higher on the scale. This feels like where things really shift gears. How different is the approach now?
You're right. It's a fundamental shift. Here, for severe pain, that weak opioid from step two, it gets replaced.
Replace, not added to.
Replaced entirely.
Yeah.
Swapped out for a strong opioid. So now we're looking at drugs like morphine or hydromorphone, oxycodone,
Hmm.
drugs in that class.
Okay. And how does it work? Just switch them over.
Well, it depends a bit on the patient. If you have someone who's opioid naive, meaning they haven't really taken opioids regularly before,
Right, new to them.
and they're suddenly in severe pain, the guidance is to rapidly titrate short-acting strong opioids. Get control quickly.
Makes sense. Urgent situation.
Yeah. Now, if it's someone who has been on short-acting opioids for persistent pain and they're stable on their dose, that's when you'd switch them to an extended release or a long-acting version of the strong opioid.
Okay, for more consistent coverage.
Exactly. But you still allow for breakthrough doses of the short-acting kind for pain flares.
Got it. And how do they figure out the dose for the long-acting one?
That's carefully calculated.
Mhm.
When converting, they'll usually start the long-acting dose somewhere between 50% and maybe 100% of what the patient needed daily with the short-acting ones. It depends on, how they expect the pain to progress. It's about balancing comfort and avoiding too much sedation.
That's a delicate balance, I imagine.
It really is.
So this latter seems geared towards managing pain, at home or in an outpatient clinic. But what about those times when pain just explodes, becomes an acute crisis? when that outpatient ladder just isn't cutting it anymore.
Right, that's a critical point.
Big.
Step 4, if you will, though it's less a step and more a change of venue.
Okay.
For those extreme situations, an acute severe pain crisis, the recommendation is to consider a higher level of care. We're talking about hospital admission or perhaps inpatient hospice care.
So moving into an inpatient setting.
Exactly. Because the goals shift too.
Mm-hmm.
In the hospital or hospice, the focus becomes achieving very specific patient-centered goals for comfort and function. Things you often just can't manage effectively outside that setting with that level of monitoring and intervention.
Right. You need more intensive support.
Precisely.
Yeah.
It acknowledges the limits of the standard outpatient ladder in a true crisis.
This leads us perfectly into something really important you mentioned earlier with dosing. Tolerance, opioid tolerance. It sounds like this vague idea, getting used to a drug.
Mm-hmm.
But the source material was really clear. It's not vague at all. It has a very specific clinical definition. And the FDA provides, well, pretty strict criteria. I found that fascinating.
Absolutely. It's incredibly precise, and that precision is vital for safety and effective treatment. The FDA's definition isn't just a guideline. It gives specific thresholds.
What?
Okay, so for example, to be considered opioid tolerant, a patient would need to be taking, say, at least 60 milligrams of oral morphine per day, or at least 30 milligrams of oral oxycodone daily, or 8 milligrams of oral hydromorphone, or even 25 micrograms per hour from a fentanyl patch.
Wow. Okay. Very specific numbers.
Right. Or the equianalgesic dose, basically, the equivalent dose of another opioid. And here's the other key part. They need to have been taking that dose for 1 week or longer.
A week or longer. Okay. Why is that level of detail so important?
Because it tells clinicians definitively when a patient's body has physiologically adapted to the opioid. It's not just about perceived effect. This helps guide decisions about, for instance, switching to stronger opioids or using long-acting formulations safely. It helps prevent accidental overdoses in patients who aren't tolerant and ensures adequate treatment for those who are. It's a critical safety marker.
That makes total sense. Managing risk while ensuring relief. So we've climbed the ladder, steps 1, 2, 3. We've talked about the crisis, step 4, and now the specifics of tolerance. It's clear this ladder is a powerful framework, but it can't just be about the pain score and the step, right? What other sort of nuances go into picking the right opioid for that specific patient?
Oh, absolutely. It's much more complex than just the ladder step suggests. Selecting the appropriate opioid involves juggling several other really critical factors.
Like what sort of things?
Well, things like the drug's bioavailability, basically. How much of the drug actually gets absorbed and used by the body.
Okay.
The route of administration is huge, too. Is it best given orally, as a patch, injection? That depends on the patient's situation.
Sure, if they can't swallow pills, for instance.
Exactly. Then there's the half-life, how long the drug actually stays active in the system. That affects dosing frequency.
Right.
Potential neurotoxicity is another big one. Any harmful effects on the nervous system, especially with long-term use or high doses. And, let's be realistic, cost is often a factor too. That's a real-world constraint for many people.
Yeah, definitely.
So yeah, considering all those things, it really highlights how personalized pain management has to be. The ladder provides the structure, but the fine-tuning is very individual.
So we've really covered a lot of ground here. We've walked through the analgesic ladder, starting with mild pain, moving up through moderate and severe, touching on those acute crises.
And the crucial definition of tolerance.
Right, and all those other factors that tailor the treatment. This deep dive, I think, really gives a solid, structured way to understand what's actually a super complex medical issue.
Yeah, what really stands out is the sheer nuance involved, isn't it?
Yeah.
It's so much more involved than just, here's a pain pill.
Definitely.
It demands careful assessment, that logical step-by-step approach we talked about, but also this deep knowledge of the drugs themselves, and crucially, the individual patient's needs and context. It's all about finding that right balance for that person.
Absolutely. And maybe something for you, the listener, to think about is, how does understanding this kind of structured yet really personalized approach to something like pain, how does that shift your view of medicine or the challenges that doctors and patients face together?
That's a great point.
And maybe even thinking broader, how could applying this kind of thoughtful, evidence-based framework, this ladder concept, almost help in other complex decisions, maybe in your work or just life in general? It's a powerful model for tackling complexity, really.